there, and for the not just GPs, the wider system team who joined. So we had some pharmacists online. I'm really pleased that there was an ask to have this regularly. I counted up all the comments at the end of the chat last meeting, and actually there was an overwhelming desire to have this and to have it at a 2-week frequency. We had at the last one 2 weeks ago, there was a plan to go through some cases from the out of hours care, and we didn't have time to cover that. So really pleased we're going to be moving on to cover that today. And the aim is to have the talking and then to have at least 15 minutes for questions and answers, which again, we found very helpful last time and hope that you did. This is the forum is for you guys. Anyone who's on the call, the forum is for you. And we want to hear how to make it work for you. And the hope is that next time, in 2 weeks' time, what we'll look to doing is paediatrics. So just really saying hello, just saying for this is also a really good way to say thank you to everybody for your ongoing work, your resilience, not just the wider team, the nurses, the healthcare assistants, the pharmacists, but also our colleagues in social care, in secondary care. Simon and is joining us with Hannah today from Barnet. I think somebody's not on mute, so if you go on mute, please. And just really another way to actually say thank you. We've got today we're going to have Anna speaking in a minute. The provision in terms of the Federation, the UCC, which is the Unscheduled Care Collaboration, working with BarnDoc, working all together as a system has been what's provided this round-the-clock care to Barnet patients. So we've been doing it daytime in our normal surgery hours, but the support for the COVID patients in hours and out of hours has been tremendous, and we're going to be bringing some case examples for that. So I'm going to, without further ado, move on to Anuj. So thank you.
Thanks, Charlotte, and it's great to see everybody back on again. And I think last week, a couple of weeks ago when we had this, it was amazing how popular and how many people actually joined in. It's a real testament for the collaborative work that is going on in Barnet, I think. And can I thank the Training Hub for setting this up and putting this in motion. So thank you guys. Just wanted to touch on a couple of bits. One was around the level of uncertainty, and I know Charlotte sort of touched on it last time. But certainly, we understand that there is a great deal of uncertainty, not just in managing clinical patients, but also in terms of services and what's going on out there. And I just want to reassure everybody that actually we are all living in a world that is very uncertain at the moment, and we are all finding our way around this. So, please do sort of feel that you can pick up the phone to any of us and talk. And I think that was the other thing around team working and communication. I think what we've found, particularly in our practice, but also within the Federation, is that actually the conversations that we all have between individuals, between our members of staff, are really key in helping people get through this difficult time. And the collaboration between practices has been amazing across Barnet, and we've seen that not just at PCN level, but also pan-Barnet level. And the collaboration across organisations, and this is you'll hear from Laura in a bit, but this is an example of where the collaboration across Barnet with the out of hours BarnDoc with CLCH has really helped in trying to gel some of the management of patients. An update with regards to the hot and home visiting. The activity is quite low at the moment, and so we thought it was a good opportunity to bring some cases and how we manage those. And I think the risk sharing is a key one, really, in terms of how people manage risk and some of the key clinical issues. I'm going to hand over to Laura in a second. I just want to do a quick update in terms of the Federation, just in terms of services. So activity with the hot and home visiting is quite low, and we're going to see that going on till at the end of June. We're also running the anti-coag clinics. Now, those are still running, and we're doing the near testing. So those are patients who may be on warfarin that you want tested, and because they're done remotely with near testing, actually and it's EMIS compatible, we think it might be helpful if you have any patients that you think can't get to the hospitals but want to be monitored, please feel free to refer them into the system. And I'm happy to pass on now. The details for all these services are on our website, and if we will try and post this and send this by email to everybody. But there is a notice board, a new notice board on our website as well, which has all the latest COVID type information. And the other thing we've added on recently is around help with recruitment. So if practices have some need for recruiting staff, we've put a system on there where we can advertise for you. So if you want to send adverts in, we're happy to do that, and I think a number of practices already started doing that. So I thought it'd be a good time to just update. What I do want to do, though, is move on to the clinical aspects, which we're all really keen to hear about. So some of the shared learning, and we have Dr. Laura Geddes, who is the medical director for Barnet, and we also have Justin, who's the chair of Barnet, who are going to run through some cases that have presented at the hot clinic and at the home visiting sections. And then we have Dr. Simon Brill from Barnet, respiratory consultant, who's also going to take on some of the clinical advice as well. So can I hand over to Laura to take on some cases? Thanks, Laura.
Thank you very much, Anuj, and thank you so much, Charlotte, for giving us the opportunity to discuss our cases and our work. And Anuj made a really important point there that we are, through this chaos, we have shown that we can collaboratively work together, have new initiatives and new ideas that come to the fore that help patients in the long term. So I'm coming at you at a kind of out of hours aspect, and Anuj and Justin will possibly jump in as well, and we'll just keep this fluid. We'll go through a few cases as well. I'm aware of the time, so it will be a very, very quick whistle-stop tour. So can you move on to the next slide, please? Thank you. So if we pan out just for a moment and look at the world, we have currently coronavirus standing at roughly 7 million confirmed cases, over 400,000 deaths. And panning in slowly towards the UK, 289 confirmed cases, 40k deaths, around 30 of which are in England. You can see the massive impact that it has worldwide. So what can we do what can I teach you about the out of hours? So what I'd like to do is go through the consultations, or the type of consultations that we do in out of hours, most of which you would know because you've been doing sessions, and then just go through a few cases. So this slide here shows that it's a little bit old, I think a couple of weeks out, but it shows that the COVID-like GP consultations have decreased during the out of hours. And we can see that if you look at the key here, I think I don't know if I can move my key, but essentially it looks like we're past the peak. And I know that Boris Johnson did say some time back at the end of April, beginning of May, around that time, that we were over the peak. I think we just have to be very, very careful about what the virus will do. And you said a really important point about uncertainty, and that does not just apply to uncertainty in specific cases, but at the uncertainty of the virus and what it's going to do, how it might evolve, when a surge might come. So we can move on to the next slide. Thank you. So the out-of-hours services in England have found that there is a slight decrease now past the peak in terms of the influenza-like illnesses. In the last week, they are still above baseline levels, as you would normally see at this time, say last year. But it is becoming a lot more manageable. And of course, you have a lot of the other the key indicators on the left with the different diagnoses that are given. And we can see that a lot of them are paneling out to the normal thresholds at this time of year. Let's go on to the next slide. So during the out of hours, and this is a lot of graphs, and I'm liking a lot of analysis on this, but we can see that there has been, in the green on the left hand side, this is the all contacts during the out of hours, panning from the mid-May last year to this year, and we can see it, as you would expect, expect. There would be a few peaks, a few troughs, but there was one around March time, end of March, which is in keeping with the peak of coronavirus. And as you can see, the acute respiratory infection daily contacts did go up, and now they are coming down slightly. Same with influenza, and the same with the wheeze, asthma, and difficulty in breathing. We can move on. So this is another messy graph, and I promise not to give you many more graphs after this, but this is quite an interesting one, because if we look at our triage number, which is the one in the grey, and this is a chart which is from from March to May, with the number of triage on the y-axis going up to 700, and the face-to-face and home visits on the left. So for the triage, we could see that the cases within our queues that we deal with during the out of hours climbed and climbed and climbed up to the end of March. And this is when we had the peak, or we saw the peak during the out of hours. The face-to-face, you can see the consultations in orange went down. Obviously, we're saying now that the staff, let's try and find new incentives, work in new ways, do video consultations, more charge. And then we have the same with the visits. They did go down, and then you can see that they've peaked up just after the triage peak, because you have a lot more visits in the care homes, a lot more confirmation of deaths, and now it's come down to around baseline levels. We can move on. So comparing ourselves to last year, looking at the total cases, there's more than 60% increase at the peak, and that goes across the board through triage, face-to-face visits, but the primary care centres is a minus, well, it's decreased 30%. That's in keeping with doing less face-to-face, like in the GP surgeries. And we can see now they are just slowly creeping up slightly, and they are around baseline levels. It's much more manageable now. So let's move on. So that was just the weekly variance, and the confirmation of death cases, we think, is an interesting aspect to put in terms of out of hours. I know it doesn't really help with your individual cases, but I think looking from a professional perspective, the kind of cases that out of hour GPs deal with, we don't see too many confirmation of deaths, but we can see at the peak from a baseline of 8, we got 10 times that, and there were GPs going out in the night doing up to 12 confirmations of death a night, and that has a huge psychological impact on the doctor as well as the patients, their family, etc. Those that are not clear on the guidelines, and as you know, there were so many different changes in the confirmation of death guidelines, and it had a very important impact on us as individuals. I know a lot of you would have had relatives or people that you know that would have passed away that may have been confirmed by their GP or the out of hours GP, but and we have a lot of colleagues here who have been affected and had to have an out of hours doctor confirm death. But I just wanted to give you the grand scheme of things here. We can move on. So now I'm just going to quickly move on to the collaborations, as Anuj pointed to, and he said it's a testament to the collaborative work that is coming out of many different boroughs throughout England and worldwide, and this is a really good example of it, where the Barnet COVID-19 Community Response Service was set up by the Feds, and the out of hours as well, as being Barndoc, help to support the surgeries that may have been running single-handedly, say, and the principal GP unwell with COVID or is in self-isolation, and also helped with the positive COVID cases at home who couldn't be seen at the time by their own GPs. And this was based at Edgware Walk-in Centre, still is. We can move on. So I'm just going to go through the cases now. I know this is the meaty bit of what you wanted to listen to and what you're really going to learn from. And I have to say that from the teaching last time and what Anu just said, the out of hour cases and in the hot clinic as well, some aspect, you know, you're dealing with a lot of risk, a lot of uncertainty. And you would have noticed that through doing your own consultations with patients over the phone, as to seeing them face to face. I'm going to hand over to Justin Peter, because he had this case in the hot clinic a few weeks ago.
Thanks, Laura, and thank you everyone for joining. And as said, this venture has been truly collaborative, and I was actually very privileged to take part in working in the hot clinic, and actually what it emphasizes actually the wisdom of crowds, because when you're in the hot clinic, you've got the ability to discuss cases with the home visiting GP and the face-to-face GP as well. On this occasion, I remember I think I had a GP trainee with me, and this case came across. It was a referral from a practice. As you can see, it was a 90-year-old that was on warfarin on AF, and actually the practice had done a routine check for an INR, and the patient had informed them that she'd had a fall in the garden, banged her head, had a lump on the back of the head, and the nurse absolutely asked her GP to call the patient, and the GP thought the patient should have hospital check. The patient was not keen, and the GP asked for a home visit. So it did raise a few issues about, what's in the patient's best interest. How do we risk assess this visit, and what's the best outcome? Does she need a home visit, and will that change our management? And my experience of this case was, we came together. The hot clinic GP, at the time, then I think there was also the cold GP was doing the triaging, and you had the hot GP doing the face-to-face, and now that's combined into one role with the home visiting GP. And we came together, and the trainee joined in on the discussion. And what we felt actually with this case was actually, maybe it's about communicating risk, because this is about uncertainty, and communicating the risk to the patient about potential bleed, intracranial bleed with a head injury with warfarin. So I phoned the patient and discussed the situation with her, and she was clinically well, stable, but we did talk about the risk of a bleed, and when it was made clear that it could threaten her life, she actually was willing to go to hospital. And what I've always done in these hot clinics is I will pick up the phone and speak to the GP who referred the patient, because I think it's really important. This is a shared management, and it's a shared decision, and that GPs need support, and we all need sometimes to share these risks. And I was able to contact the practice and speak to one of the GPs who agreed actually that the patient could be transported by ambulance to the hospital, because she needed a CT scan of her head, and I had to balance that with the risk of sending one of our GPs on a home visit to this patient. And would that change our management? Probably not. So these are the sort of challenges that we face in the clinic. And it was helpful to speak to the GP practice that referred the patient. So there's a sort of mutual respect and understanding about the decisions being made, and having a huddle. Not too close, 2 meter distance, and certainly no one crossed the threshold between hot and cold. We discussed at the hot clinic, what were the issues, and it was really powerful collaboration in a challenging risk environment. So if there's any questions about that, by all means put it on the group chat. Maybe that's a bit more of a straightforward case. If you want to move to the next case.
Thank you very much, Justin. So this one was an out of hours case and was triaged by one of my colleagues. We'll see how we go. I may ask for some comments on the chat. We'll see how we go with that. Otherwise, I may just give the answers as well. And in the future, we'll jump straight into cases from an out of hours perspective. So triaging GP spoke to a 69-year-old female. Well, actually, she spoke to LAS. 6-year-old. She had a background of COPD, AF, epilepsy, and alcohol dependence, as well as depression. She presented with 3 days of cough, which was productive. When they examined her, the LAS, they found that she had a regular pulse, 60, respiratory rate slightly increased, but SATs of 89 to 90 on air, which increased to 96 on O2, and she had bilateral COPs. So suspected COVID at that time, and she'd refused admission. LAS did not think that she had clear capacity, but didn't want to forcibly remove her and take her to the hospital. the GP felt that she didn't have capacity but wasn't sure, and she was unable to do a fresh set of eyes, just look at a case from a different perspective. Sometimes that collaboration together on a one-to-one level really does help. So what would you do in this case if they come to you and said to you, I'm not sure what to do, can you help? I don't mind just typing anything in the chat function here. Lots of different options. We can say she has no capacity. Let's force a mover. She has clear capacity. Let's keep her at home. If you're keeping her at home, would you do a home visit? And it's challenging, I think, to deal with that level of risk, especially when you don't know your patient in front of you, and the uncertainty of what might happen if you do decide to leave them at home. So what happened in this particular case? I said to her, I haven't met the patient. I haven't spoken to the LAS crew. I think what would be useful for me is have a talk with the patient and see whether I think she has capacity. So I know they say too many cooks spoil the broth, but I felt that this was really necessary in this case for me to understand the patient's point of view, why she didn't want to go, whether she had alcohol on board that may have subtly affected her decision. But I found her to have capacity. So she hit all the buttons for managing capacity, meeting capacity. She had it. She can make her own decision. And she said that she wanted to stay at home and she was happy if she were going to die from this because she didn't want to go to hospital, it being full of COVID, despite the fact that she knew that she could possibly pass away. Now, she didn't have anybody at home with her. So I thought that it was pertinent to get another kind of thing. So she was seen by a visiting GP, was given antibiotics. Luckily, at that point when he saw her, her SATs had crept back up again. So that's really reassuring. But I think we do have to bear in mind the possibility that they could deteriorate at any time, which is why it was important. We can move on to the next case. And I know I'm going over my time now, Simon, apologies. Case 3. So this was out of our case that I saw as a home visit. It's a 68-year-old chap who had metastatic esophageal cancer. He was, prior to me seeing him 3 weeks prior, he had been on the roof, was fixing something on the roof, very mobile. And although that he was semi-palliative, he was doing really well. He had a very bad decline over the previous 2 weeks, just generally, and he was managed 2 days prior to me seeing him for UTI. They thought that he may have had a TIA a few weeks ago, but they didn't follow it up because they felt he was palliative, and therefore, what would possible intervention do to help at this stage? I'd seen him because he had an unwitnessed fall from the sofa, and he didn't have any pre-existing issues other than the cancer, any chest pain, dizziness, lightheadedness, or anything prior to the fall. At presentation, he was unable to move his left arm, and he was quite confused. And on looking at, someone said that they can't hear. Can all of you hear okay?
Laura, it's just patchy. Sometimes you end up going out. Can I just ask if anyone's not on mute, please can you go on mute, because that does help with the quality. Thanks.
Thank you. Apologies. I'll try and speak a little slower. When I saw this chap, he was slumped to the left side. Slightly high, but otherwise there was cardiorespiratory compromise, but he was unable to lift his left arm. He had a reduced grip. He was able to get up and mobilize, but with assistance. And he could only say yes or no. There was no speech slurring and no facial weakness. So what could have happened to him is what I'm going to ask, if you can hear me, that is. Any diagnoses? Fall onto the floor from the sofa, hurt his left arm. was a slightly painful, odd sensation. That's right. Yeah, you're absolutely right. So at first, when I heard the history without looking at the patient, I thought, is it a fractured arm? Is it a stroke? Could he have had a bleed? What medication was he on? And all these questions popped up in my mind. So I thought that he may have had a stroke. That was my first decision. And the second thing to do then is decide, what do we do with him? What I said to him, if he's had a stroke, depends on his ceiling of care. If he is for hospital management, which he was, he would have to go in. So I called the LAS. You're right, BM was normal. I was just responding there to Justin, to Joanna. Brain mets, yes, a possibility again. So all in all, did it require hospital management at home? And he said, happy to go in. So I got the LAS crew out and they assessed him. There's a family present, and the wife said, we don't want him to go in because we're not going to be able to see him. Someone's not on mute, sorry, thank you. And there was a lot of chat amongst the 4 or 5 family members who didn't want him to go in. He then wasn't sure and couldn't make a decision. And it was challenging because, up until 2 weeks previously, he was a very unwell man. So he was very functional, who was able to do his normal things and climb on the roof. And now it felt like we had to come up to deciding a ceiling of care. What would be in his best interests? Are the relatives coercing him? Do they have power of attorney? And that kind of thing. So he then, I think, was slightly confused after a while, and we tried to assess capacity. And in the end, we decided as a collaborative team, that's myself, the LAS, and the family members, that we would keep him at home. And we would get the palliative team to come in and review him and get his GP to see him as well, whenever they could. So it is about not just what is their ceiling of care, but you have to realize that explaining to them, what are they going to be able to achieve when that patient goes into hospital? If it's a brain met, are they going to do anything other than give him some dexamethasone, which he was already on? Are they going to drain bleed that was suggested? And what how would that level act in able to be visited by any of his relatives? And I think that overall we did come to an agreed decision, and the family were very pleased that he was able to stay at home, and eventually he was happy too, as well as the LAS. And so they left, and we just wrote to the palliative care team. I spoke to North London Hospice, and we refer back to the GP. We can move on now. So the challenges and solutions within the out of hours is, you do have a lot of fear about the staff, and this goes across the board, not just out of hours. And that's why we have things like risk assessments, we have shared knowledge, we have the adequate PPE, which I know some people may say, oh, we don't have enough, but there is that discussion amongst our colleagues. The verification of death was a tricky and challenging situation because the guidelines kept changing. Unexpected deaths from COVID, who is going to see them and what you're going to do? And that's where the pandemic multi-agency response teams came about. We can discuss that at a later teaching session, but essentially involves the police and doctors as well, seeing the unexpected deaths from COVID. You have your GP staff in isolation. That's why we have cohesive teams. We have collaboration, like Anuj said, like Justin said, and we have teaching and shared learning. And I think that it is, as I said before, a privilege to teach you guys, because there are so many, from a teaching aspect, there's under your curriculum and your competency areas, you're looking at how do you work with your colleagues and in teams, in and outside of the working hours. How do you gather and interpret all of the information that you're gathering from your patients? What information do you have in front of you, and out of hours it's less than what you would have within the GP practice. The risks and managing uncertainty, the clinical management of the patient who will be chatting about the respiratory effects of the COVID-19. Thank you. Oh, I've got one extra slide, a bonus slide. It's about the future, and we don't know what's coming up in the future. But a lot of all these things on the side there are taking place. Vaccinations, you know, we're far off. Quarantining contacts, track and trace. Should we have released lockdown as early as we have? And that's, it's all exciting, and this is where we're going to have interesting discussions over the next few weeks, and seeing with the current situation in London and abroad with a lot of this violence and crime and protest, is that going to have any effect on a possible second surge? Thank you.
Brilliant. Thanks so much, Laura. I think just in the interest of time, we'll hand straight over to Simon. If you have any questions for Laura, please, from Laura's talk, please just post them in the chat, and we'll address them all together with questions for Simon at the end. Over to Simon now. Thank you. So Simon is, so Dr. Simon Brill is a respiratory consultant from Barnet. He joined us a couple of weeks ago. We're very happy to have him back, just to follow up on a couple of the points raised last time.
Okay, thanks. Let me know if you can't hear me for any reason. Hopefully this all works. I'm not going to talk for long at all. I've not prepared slides. I thought I'd just give a very brief update on what's going on in the hospital and what we're doing in terms of follow-up of the patients that we have had through the hospital, and where we are with that. And then last week or 2 weeks ago, the questions seemed quite helpful, so we can just take some more questions again. The picture in the hospital at the moment is that we currently have very little COVID, thank goodness. We do not have more than, I don't think we've had more than 1 or 2 positive tests in the last fortnight, with very few suspected cases. So locally, at least, it feels to us like the peak has passed. Obviously, we're remaining vigilant. The difficulties we're currently grappling with are regarding reopening our normal services, which is incredibly difficult in terms of infection control and the differing work streams we're having to maintain. In respiratory, for example, that's particularly difficult around lung function and bronchoscopy, both of which are aerosol generating, and that's proving a real handicap. It turns out retrospectively that it was much easier to shut everything non-urgent down and step up the urgent response than it is going the other way, and that's what we're grappling with at the moment. The other big work stream that we addressed a little bit a couple of weeks ago was around the COVID follow-up. So the aim is that we proactively follow up every patient that we've had admitted through the hospital, and then also have an entry into that work stream for referrals from primary care. So just to give you an idea of what we're looking at. So far we have telephone called 114 or so of our discharges, and the good news is that most or the majority of them, so 60 or so of that number, we've essentially discharged pretty directly from further follow-up because they're making a good recovery and don't have significant ongoing issues. Of the remainder, we're bringing about 35 back to clinic in 6 weeks for another follow-up because they have some remaining symptoms that we'd like to track through to resolution, and some remaining radiographic abnormalities on chest x-rays. So obviously our big concern is about the lung scarring and fibrosis that may emerge from this. Of the ones we've found, less than 10 have actually needed an urgent review. And actually the issues that my colleagues have been finding are almost incidental and mainly geriatric type issues. So there's been an issue of worsening heart failure. Another patient had an intercurrent UTI and had become delirious and declined, which was, they hadn't sought help for it, but because it was picked up. And someone who possibly had a stroke and was referred in urgently. We've not had to refer in urgently for many of the kind of dreaded post-COVID complications like PE. I suspect most of those people are seeking help proactively, and certainly a couple of our severe COVID patients we've had to readmit because they've presented with worsening symptoms, one for a pneumothorax, one for a possible lung abscess. But the other big thing that people are finding and people are reporting, I know to you from the questions last week, is pronounced and really quite disabling fatigue, breathlessness, potentially dysfunctional breathing overlay. And interestingly, we're picking up quite a bit of
Simon, we can't hear you at the moment. Just wonder whether it's worth dialing out and dialing back in again, and whether Anisha, you want to pick up some questions while he's doing that.
Yeah, sure. So we've had, as somebody's written, so PCM3 guest, I'm not sure if that is written. We've had a couple of patients presenting with pericarditis, thyroid disease as a result of complications of COVID-19, have been recovered well, not problematic. I don't know whether Simon, Simon back on. I don't know whether Simon, you've seen any cases of pericarditis or thyroid disease in the hospital, but somebody's posted a query about.
Can anybody hear me at the moment?
We can hear you now, Simon.
I can't hear anyone else either. Sorry about this. Okay, apparently I can be heard. I've changed microphones to the webcam. Right. So essentially, I think I was just saying that there appears to be an element of survivor's guilt and psychological disturbance in a lot of the patients that we've been calling following hospital, which is understandable, because at the height of the pandemic, obviously, a lot of the people were in bays where people around them were dying or were being carted off to ITU, and it was quite a frightening process, particularly for people who were in for a long time. So that's not surprising, and we're referring them into IAPT and local psychological support services where that's identified. The only other thing I wanted to mention also, that Charlotte and I have been in discussion, hopefully within a few days, we're going to be able to offer a COVID advice line through secondary care, essentially, which will roster between the respiratory consultants and have a point of contact, probably in the afternoons. The details are being confirmed, but will circulate so that if you have queries, you can phone in and just get some quick advice. That won't be a substitute for the urgent referral pathways for somebody you think needs to come to hospital, but would be potentially another service to help manage some of these things and really share the decision making, because that's obviously a luxury we've had in secondary care, which maybe isn't as easily available in primary care, but we're all sort of stabbing in the dark a little bit, and just to try and share some of the decision making is helpful sometimes. So that's all I was planning to say, and very happy to move over and share questions with Laura, if that's the correct next step, and probably in the chat is the easiest.
Brilliant. Thanks. Thanks, Simon.
Shall I just go through some of those?
Yeah. So if you start, there's a couple of queries about thyroid disease, and Justin's asked about rehab and back up.
There was a question for Laura probably about practices having a set-up plan for future opening. Do you want to take that one first, Laura?
Oh, I don't know if I'm the right person to take this.
Sorry, it's Justin here. I think that's an answer for Anuj, really, and Charlotte.
Charlotte and myself. I mean, I think it's there has been an NHS SOP for general practice, which is quite useful, and there have been some locally developed guidelines elsewhere. We are looking, and we're talking to the local team around trying to put some advice out for practices which might be helpful around zoning and how to manage staff and patients through practices. But certainly we can take this and bring it back to you next time if that's okay. Charlotte, I don't know if there's anything you want to add.
Yeah, so just to add, a lot of this work's being done in the primary care recovery group. So I'm chairing that, and that's got representation across NCL, and Alexis is the CD from Barnet who's representing on that. We've got patients, we've got LMC, we've got Federation representation. So there are 3 core areas that are being looked at. One is sort of patient access and experience. The next is multidisciplinary team working across PCN footprints. And the third is workforce and resilience. And as part of this, and Anna's reference about the zoning, there'll be a questionnaire coming out to practices to work out, what is the ability, and there will be a significant number of practices in Barnet that don't have the ability, and NCL that don't have the ability to zone because of just the nature of the estate that we've got, and really just trying to find out what's going on and work out a plan. So I think thinking about things on an individual practice basis is definitely helpful. There will be guidance, and we're kind of caught between, we're still in an emergency response. So this kind of OPAL 4 emergency response hasn't finished yet, although we're planning for recovery. And Simon helpfully describes that in the hospital, and they're getting going with their elective care and prioritising who they do first. In primary care, we're working that out as well. And the SOP as reference that came out last Friday, a week ago, is somewhat helpful, somewhat lacking, but then we need to work out the London and the NCL response, and we're not looking for an identikit across every single practice in every single borough in NCL. There are differences in different boroughs, but that work is predominantly happening in the primary care recovery group. What I am hoping is going to happen is in the bulletin, in the NCL bulletin, there's going to be a summary of what's been discussed in the groups, so that everyone can have a sense of what's going on. So it's not just the people on the group. Although there's very broad representation, it needs to be we really want this to be bottom up. We want this to be hearing from all the grassroots. So I'm hoping there's going to be a summary in the bulletin that will then enable you to liaise. It will be in the first place with Alexis or myself, giving that Barnet view.
Okay, thank you. So just going down the rest of the questions. Again, tell me if you can't hear me. I'm going to assume you can, but this isn't working perfectly. So there was a comment really about a couple of patients presenting with pericarditis and thyroid disease, which certainly sounds very plausible. I don't think we really understand fully what this disease can do yet, and I think we just have to be reactive as best as possible to the problems we see. Just scrolling down again. So in view of some presentations of thromboembolic disease, last Friday, a patient of 40 years old had a collapse at home with no other risk factors, believed to be CVI or an MI, not had a post-mortem. I mean, that's obviously hugely concerning. I don't know how to kind of anticipate those. And certainly there was a signal in the news potentially about people being found at home. Obviously, people are more isolated in lockdown as well, and that may be something we're seeing more and more. There's a question from Justin about plans for rehab and follow-up. That's something that we're working on through secondary care. So what we're in the process of setting up is at 3 months, the clinic that we're going to have for COVID follow-up is going to be a multidisciplinary clinic involving physiotherapy, and we'll also have an MDT attached to that clinic, which will be a sort of an access point for physiotherapy in secondary care. And that, I think, is going to have 2 main functions. One is for the dysfunctional breathing aspect of this, which generally should hopefully respond well to physiotherapy input. But the second aspect will be around rehab. And I think there's probably more of a piece of work to be done in terms of the post-COVID rehab, which isn't really a specialty or an access for pulmonary rehab that we have at the moment, but I suspect is going to be both needed and beneficial. I suspect we're still trying to work out what the scale of that demand is, but that's certainly something we're looking at. Next question was about a little more about thyroid disease. That's interesting. That's not a signal that I've seen post-COVID, and it may be something that emerges. I will definitely keep an eye out for that. Charlotte has mentioned about highlighting bloods for patients with ongoing breathlessness. At the moment, we would recommend in primary care doing standard bloods, not things like D-dimers or troponins, because the difficulty then comes in interpreting those without easy access to the additional tests you'd need. So we're also in the process of working up the kind of pathway or the sort of streamlined pathway into our follow-up protocols. But essentially what I suspect we'll be recommending for patients who are breathless and whom you're considering requesting further advice for, we would ideally like a chest x-ray, oxygen saturations, and routine bloods, which is blood count, Usenes, CRP, and liver function, at the point perhaps of seeking further advice, because those are just very useful baseline investigations to have when we're discussing, and would pick up the patients who need urgent referral. We wouldn't suggest D-dimers or troponins at that point. I would suggest anyone who you're considering those tests probably needs to be seen in secondary care. The other thing to mention is that we've been liaising with our ambulatory care service at Barnet, and they have agreed that they will pick up the urgent reviews for these patients. So if we discuss, or if you have someone who you're thinking of bringing in, the urgent referrals are likely to be seen in AEC. So not the emergency ones that need to come to A&E, but the ones who need to be seen within a day or two. AEC will pick those up and do D-dimers and CTPAs if needed. And as I say, once we've got the advice line set up as well, we'll pass on what we see as the pathway for referring those patients in, but it's likely to be via AEC for the ones who need a quick review. So hopefully that answers that. The next question was about opening of surgery doors, which I think has already been dealt with by Charlotte and Laura. Then Amma Faruqi says, I've had a couple of patients admitted with severe COVID symptoms and then subsequently classic CT appearances, but negative swab results ×3. Could you explain? So this is something we've grappled with in hospital at the height of the pandemic. These patients who you are convinced clinically and radiologically have COVID, but who repeatedly test negative. And there's, I think, several reasons for that. We think that the positive predictive value of the swabs is about 70%. So you miss probably 30% of true COVID cases based on the swabs. And then by doing a second swab, either you'll pick them up because it was a sampling issue or a test issue the first time, or perhaps you've just simply missed the window and that patient who did have COVID is just no longer shedding virus, and what you're dealing with is almost the post-COVID lung inflammation and organizing pneumonia. And those people had it. But we certainly recognize the phenomenon of people who absolutely had COVID in the height of the pandemic when it couldn't really have been anything else, but who just test swab negative even up to 2 or 3 times. And those people we've simply labeled as clinical or clinico-radiological diagnosis of COVID-19 and treated them as such. At the height of the pandemic, we were just, basically everyone who came in had COVID. Even if they presented with something else, they still seemed to have COVID. And I think at that point, the pre-test likelihood was so high that even in the negative, you would regard that as a false negative test. So those people we've labeled as clinical COVID. And then a couple of questions about thyroid disease, pericarditis and bloods. Again, as I say, there are all sorts of signals around this emerging, and it's just a question of responding to the patient in front of you, seeking help and referring up as needed. And I think gradually we'll get a more complete picture of the disease that we just don't have at the moment. But it can certainly, it's a multi-system disease, there's no question about that. And it can affect people in lots of different ways. So will there be any post-COVID review clinics in secondary care? Yes, absolutely. We've got the pathways set up, and there will, as well as the ones we're proactively following up, of course, we don't know about the people who didn't present to hospital first time, and those are the ones we would want you to bring into the pathway for us to follow up. So what's the next one? Unless people inform the GP surgery of a positive test, the GP surgeries don't receive the results. How would you follow up patients who've been found to be COVID positive, but the data not sent to the GP surgeries? Tricky. We obviously don't know about those necessarily either. We only know about the population who came through our front door. It's really difficult. I think probably those people, I suspect, will have to rely on the patient self-presenting to you, or saying, look, I had a positive test and I've still got symptoms, and then they can be plugged into the pathway in the normal way. I'm just conscious of time. Charlotte, looking at you, should I carry on? Just give me a thumbs up if you want me to carry on with what I'm doing for the moment.
I think it's brilliant. I'm just wondering, we kind of said that it would be good to keep to 45 minutes to keep the frequency going. I think we've covered it. There's some of the questions that have come up repetitively. I think it's been incredibly useful. And I wonder whether we should just keep the questions. We'll be coming back again in 2 weeks' time. We're going to aim to have a paediatric focus, but there'll be a chance for sort of general questions as well. I think it's been tremendously useful, Simon. I really want to say thank you very much. Thank you for your work today, but also thank you for your work in setting this up for Barnet patients in Barnet Hospital, setting up the follow-up, and also the description of what we should do, the basic investigations that we should do as GPs if we're concerned about somebody in primary care. Really want to say also thank you to the Training Hub and to Anisha for putting this together. You know, it is fantastic. We're working together. I've seen on the participants list, there's 120 of us that are here. And actually, had we been physically somewhere, that would have been difficult. It's difficult with sound sometimes. Sometimes people end up getting thrown off. It isn't perfect, but actually it's remarkable that we're either in our homes or our practices actually joining together. So really want to say thank you to everybody. And thank you to Laura for those 3 really interesting cases, which highlight some of the really tricky patients and tricky conditions you find yourself working in with the out-of-hours services. And it's interesting, the theme from what we've all said, starting from what Anuj said at the beginning through these cases, and then through what Simon's describing, is collaboration and discussing it together. And that's particularly useful for us in primary care. Some of us are in small practices, some of us are in larger practices, but actually where there is so much unknown, it is just the only way forward is actually discussing and kind of getting consensus views together that make it easier to give with confidence an answer of consensus view to our patients, and that gives confidence to ourselves as well. So really thank you to everybody. Yvette's posted up the email and the details of the date of the next support group. So just a reminder, there's support group is for GPs, but also for wider practice staff, and I'll put that on the bulletin again. So just want to say thank you to everybody. Thank you for your feedback. And I think in anticipation of the one in 2 weeks' time, that's going to be on a PEDS highlight, start thinking about what you want for the one after, and we will try to plan for that. So many thanks to everybody, and love to see you guys.